3, 2, 1, go.
Hey everyone, welcome to the second half of the video on wounds and bleeding. This is where we're actually going to talk about some practical, hands-on examples of how we would deal with severe bleeding in an actual real-world circumstances. This is going to be important for you because when we get together on that weekend and do practical skills, you're going to be the one that's expected to do this. So I want you to pay attention to sort of some of the priorities and some of the issues, because I'm going to present to you with a very different scenario, but you'll need to be able to apply the same skills and the same clinical practices to make sure that your victim is cared for well. So let's imagine a scenario where we're out in the woods and we run across somebody who clearly has been faced with trauma. A bunch of wood, maybe a dead tree looks like it's fallen on the person. It looks like the person was maybe whittling or something before the wood fell on them. So we run across that person. What's our first priority? Number one priority. What should have popped in your head is safety. And if it didn't, shame on you, because the first thing you've got to prioritize is your own safety. You getting wounded, in addition to the victim being wounded, is not going to help them. So even if you want to be Joe or Jane hero, the way to be a hero is to stay alive. And if you're not alive, you're not going to be much of a hero because you're not going to save anybody. So here's our victim. We've run across this person in the woods. Wow, this is looking bad. Clearly there's some wood that's fallen on this person. It looks like there's a knife sticking out of their leg. What's the first thing I'm going to do? I'm going to watch out for my own safety. So a lot of wood has fallen and injured this person. Is there any more? Was this an avalanche? Is there the possibility that there's going to be injury to me? If so, before I go into that area of danger, I want to make sure that I'm well protected, especially if I'm a lone hiker, because there's not going to be anybody to save me. In this case, I'll clear out the debris, lift off this lumber that looks like it's done some serious damage to this person's leg, and then assess the scene for safety. And it turns out, I'm not liking this scene too much. It looks like there's more wood that can fall on me, so I'm going to do an emergency drag. Normally, we don't move a patient until we're sure that patient is stable, or at least as stable as we can get them. But if there's an emergent risk, if there is a threat that is going to jeopardize your safety, then you want to get yourself and the victim out of that area of danger. So I'll show you how to do this in person, but I'm going to lift the patient, get a secure hold, holding the head as well with my inner arms, and drag that patient out of the zone of danger. In this case, wasn't much of a move. Now the patient's perfectly safe. Okay, I just want you to be aware, number one, safety. Have I said it enough? I hope so. Okay, now I'm looking at the patient and I'm looking at possible injuries. What are my priorities? Well, you know how it goes. A, B, C. Is that right? Nah, it's not exactly right. Sometimes it's C, A, B. You got to check airway for sure. You got to check breathing. You're evaluating the whole patient. You're going to look at the patient's level of responsiveness, etc. But before I do any of that, I want to get an assessment basically of the patient's condition. Just a preliminary sense of the risk this patient is facing. So I walk up to the patient, and as I do, I notice, wow, bleeding on the right leg, knife in the left leg. I'm going to check the responsiveness. Hey, are you okay? Are you okay? I get no response. It only takes a second to open the airway, so I adjust the head carefully, tilt the head back, and open the airway. But I'm not going to mess around with CPR or anything like that, because any amount of CPR is not going to save this patient if I don't stop the massive bleeding. That's not true of all bleeding, but in this case, I've got life-threatening bleeding. So imagine this is my wound here, and I got blood pulsing out of it. What does that tell me? It tells me I've got an arterial bleed. That is risky. In a matter of a few minutes, this patient is going to run out of blood, and you know that running out of blood is not good for your health and welfare. So I'm going to deal with this immediately. How do I deal with this immediately? You know how I do it. I apply direct pressure. It's going to hurt. So if this patient were conscious, the first thing I tell them is, hey, this is going to hurt, but I've got to do it. Why? Because if I don't tell them that, then I'm going to apply pressure, and they're immediately going to say, stop, 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 that hurts. Yeah, I know it hurts. If I tell them ahead of time, then maybe they will grunt and bear it and understand what's going on. But either way, I'm not stopping because the patient's life depends on it. If I've got some dressing, that's fine. If I got a piece of sterile gauze, that's awesome. If I don't, I'll use whatever I've got. In this case, I've got a portion of a ripped up t-shirt. That's just going to have to do. I put it on the wound. Now, I'm also watching out for my own safety. So before I even put it on the wound, before I do anything, If I got them, I'm putting on gloves. I don't know this patient. I don't know the scenario. I'm going to protect myself with some gloves. Yeah, this is taking a minute, and the patient's bleeding out. But I'm not going to create 2 victims today. I'm going to keep it to 1. So I got my gloves on. Now I apply direct pressure. The same kind of posture you would use for CPR with a fair amount of force. And if the patient were conscious, the patient would be screaming. Why? Because I'm pushing into a major wound. That's going to hurt, but it's necessary. If I can identify where the pulsing blood is coming from, if I can locate it in the wound, then I'm going to put particular pressure there. If I apply pressure and it seems like blood is still seeping around the perimeter, I might pull out some gauze. Yep, that's not gauze. Pull out some gauze. Start unrolling the gauze and stuffing it into the wound, packing the wound with gauze. That'll mean that when I apply pressure, the pressure goes out omnidirectionally and will be more likely to stop the bleeding and cause coagulation and a nice clot that stops that bleeding for good. But in this case, I'm just applying a lot of direct pressure. Is it stopping the bleeding? No. So I wait for a little bit, it's still not stopping the bleeding, and I'm alone out here, and I'm not sure the patient is still breathing. That's a problem. I'm not gonna mess around. I'm going for step 2. Step 2, tourniquet. Here's a manufactured tourniquet. You might or might not have one of these. I'll show you this in a bit. But if you don't have one, can I still apply a tourniquet? Sure. I can use a t-shirt, in this case, a triangle bandage, anything. And I want to do this fast. So I roll it up, flat folds, into about a 2-inch strap. Why do I want to do it fast? Because while I'm doing this, if I'm alone out here, there's no pressure being applied to the bleeding, and I need to stop the bleeding. That's my number 1 priority. So now I've got my tourniquet. I get it under the leg. I tie it in a half knot. I grab myself a stick that's not, where's my stick? There's a nice stick that's not going to break on me. I tie it again over the stick. That's a windlass, and I start tightening it. When do I stop? I stop when the bleeding stops. I don't get satisfied with the bleeding slowing down. I stop when the bleeding stops. Once the bleeding stopped, I can pull out tape. Oops, that is firmly secured. I just got a new strap for this stuff, so it's holding in place really well. There we go. I can pull out some tape and I can tape it in place or any other way to secure it. So that is sort of a makeshift emergency tourniquet. However, you've all been trained in first aid. So are you going to have to use a makeshift tourniquet? Maybe, but it's very likely you're going to be smart enough to carry a tourniquet with you. Here's a tourniquet. It's a nice orange. Why do I like orange? Because you can see it. We talked about this when we talked about the lecture. You want to make sure that the tourniquet is visible. In this case, I expose the leg. There's my wound. It's bleeding profusely. I attempt to hold pressure on it, and if you're good, you can hold a little pressure on it as you apply the tourniquet. Is that vital? What's vital is you apply the tourniquet. What's secondary is that you stop the bleeding while you're applying the tourniquet. In other words, get the tourniquet on. I pull it through. Make it as tight as I can. Make sure the windlass is available to me and has the range of motion I need. Notice the tourniquet is a couple of inches at least proximal toward the body from the wound. Putting the tourniquet here will not be helpful. It used to be the case when I was initially trained that they said put the tourniquet as close as you can to the wound. And the reason for that was back in the 70s and 80s, when you put on a tourniquet, there was a decent chance you were going to lose the leg. And so you wanted enough bone and muscle left so you could attach a prosthetic. Yeah, that's pretty disturbing, right? Now, don't worry about it. Your number 1 priority is to stop the bleeding, put the tourniquet on. If you do it right and we move fast, nobody's losing a leg today. So I put it on tight. I make sure the Velcro is securely attached all the way around. Sometimes I'll see people put on these tourniquets and they just push the Velcro down like they're putting on a boot or something with a little Velcro strap on top. Half an inch of Velcro isn't going to be enough to hold the pressure you're going to apply on this tourniquet. Put that Velcro all the way down, twist the windlass. When it gets nice and tight and the bleeding has stopped, you lock the windlass in place, put the Velcro over it, pull out your pen, write the time that you applied the tourniquet. That's going to help the vascular surgeon later when they're figuring out how to get this leg back together. They will know whether perfusion has been stopped for an hour, 6 hours, or 12 hours. And their approach to this wound depends on how long the extremity is gone without blood. Now I'm good here. I got a knife in the leg. That's disconcerting and bothering for sure, but it's not bleeding. It's not a life threat. So now I go back to my ABCs. I've got to deal with the emergency life threats. This matters, but it doesn't matter as much as keeping the patient alive right this second. So I get back to the patient. The airway is patent. Remember what patent means? It means an open functional airway. There's nothing blocking the airway, and the patient is breathing. If the patient's not breathing, I start respiration. If the patient has no pulse, I start CPR. I do all of that, and I ignore the knife for now. If the knife were in the chest, I can't do CPR with a knife in the chest, so I'm going to pull that knife out. That's one of the only times you're going to pull out a penetrating injury. Otherwise, you leave them in place. Abdomen, leg, arm, I don't care. Leave them in place. Pulling them out creates a further injury. You only do it when strictly necessary. So in this case, I've got a patient now who's got a stable pulse, maybe like 140, 150, certainly a little tachycardic. People get tachycardic when you start cutting holes into their legs. And good breathing. So I'm good with my ABCs, except that now I got this wound. So clearly the thing to do is pull it out. No, it's tempting though, right? The thing to do is stabilize it in place. So one trick that I like to use is a couple of gauze rolls. First, I'm going to expose the injury. That's an easy way to do it, but in your first aid kit, you should have something like this. Trauma shears that will allow you to just very quickly cut that and expose the whole thing. Why am I exposing it? Remember in the lecture I explained this, because you don't want to presume there's only one injury. I want to see the whole area. Did that knife go through 3 or 4 times before it finally stuck in place? Is there another injury on the back? Is all the blood the result of this injury that I've now stopped, or is there additional injury? I want to evaluate the situation. In this case, it turns out that knife is the only other problem this person has, so I'm going to stabilize it. In this case, I'm going to put a gauze roll on either side, and then I'm going to pull out my tape, and I'm going to secure that in place. And I'm going to put the tape perpendicular to the gauze roll on either side of the wound. And I don't like spending a lot of time explaining this, so I'm not going to do a full stabilization, but you'll get the idea. I'm crossing it over. Did I cross it over on that side? Yeah. I'm crossing it over, doing multiple tape covers. And the reason for that, if you were in a hospital, you wouldn't do this. Don't be mistaken. If you are in the ER and somebody comes in with a knife wound, you're not pulling the knife out. You're going to leave that for surgery. However, you're probably not going to put all this tape. Why am I putting all this tape? Because we're not in a hospital yet, and we're going to be putting this person in some kind of makeshift stretcher to get them out of the wilderness scenario into the hospital. That means it's going to move around quite a bit. So I want to stabilize it as much as possible. In this case, you're not going to do this, but if I try to wiggle this knife, it's actually in there pretty stable and pretty secure. Would it be crazy to put more tape around it? No, in fact, I would put more tape around it. I'm not going to put a lot more tape because I think you get the idea. Let me show you a trick here. Give me 1 second as you look at this wound. I go back to my campsite and I grab something, anything, in this case, a container of powdered drink, and I can put it over my knife wound right there. And then I could take my tape, maybe duct tape if you got it, and start wrapping this around. That way, if it takes a hit from one side to another, I'm not moving the knife. My goal is to stop the knife from doing this, because the more it does that, the more probability there is that it's going to hit an artery. Right now it's not bleeding, but maybe, just maybe, it's 1/4 inch from an artery. And if I do that, now it starts squirting like an oil well. That's not good. So I want to make sure I don't move it at all. So I could put something like that on, cover it again in a bunch of tape, get it as stable as possible. Once I've done that, I assess the rest of the patient, right? I got this bleeding still stopped. That is not bleeding. The patient is breathing, has a good heart rate. Now I can do a little bit of detailed assessment. Rub my hand along the back, the sides, the back of the neck, the back of the head. This person just got overtaken by a bunch of timber. There's possibilities of other injuries. Maybe I need to deal with them, maybe I don't. But I don't want to get surprised. I don't want to be 3 miles into the hike out of here before I find out that they have a major head trauma that I never addressed, right? Once I've done that and the patient seems stable, I want to reassess that patient about every 5 minutes. So ideally, if I'm alone, that means I'm going to have to put together some kind of makeshift stretcher and get them out of here if I have no phone connection. If I have phone connection, I'm calling 911 for sure. That was my first step, obviously. If I'm with other folks, I continue to watch this patient as others build me some kind of makeshift stretcher if we need to get them out on our own. Ideally, though, that's not the scenario. Ideally, we can call 911 and get some kind of emergency rescue, maybe a helicopter out here, something like that. But realize that that doesn't take the burden off you. That helicopter is going to take 15, 20, 30 minutes to get out here, and this person's going to bleed out. So every skill we've talked about is vital to allowing this person to survive until we can provide emergency extraction. Okay, that's it for bleeding control, but realize that we're going to go through this again with a lot of hands-on skill in person. So this is basically to give you a preliminary idea of how we deal with bleeding. I'll see you in the next video.